Good afternoon, everyone. My name is David FitzGerald. I am the co-director of the Center for Comparative Immigration Studies, and we are delighted to welcome you to the final seminar of our series this quarter. Today we'll be hearing from Dr. Tala Al-Rousan. She is a physician and researcher here in the School of Medicine at UC San Diego. She'll be talking about an extremely timely topic, which is a public health perspective on refugees and the global COVID pandemic. The way that we'll proceed is that in a moment, she will take about 30 minutes to give a presentation. If you have questions, please send them to me via the chat function, either during her presentation or at the conclusion, and then I will collate the questions. Presentation. So without further ado, we are, again, very happy to have Dr. Al-Rousan share her expertise. She has been working in Jordan and the US on refugee issues, and I will turn the program over to her. Welcome.
Thank you so much, David. Thank you to everyone who's attending today. I know there are so many people attending from overseas as well, so a big shout out to my friends from South Africa, from Canada, and from Jordan. Today I will be sharing my screen with you, and I hope you can see it. Can you? Yes? Perfect. I will be today talking about the issue of refugees and COVID-19 and talking more about the public health perspectives, the medical issues that are going on, and I was thinking maybe we could structure it by talking before about the pre-pandemic context, how displacement or forced migration is a global challenge, is the pandemic on its own, and what happened when COVID-19 has hit refugees, what is the current present status of COVID-19 and refugees. And finally, I'd like to discuss some future challenges, as well as opportunities and ways also we could contribute in our own ways. I like always to start with what is the definition of health. A little refresher, according to the World Health Organization, health is a state of complete physical, mental, and social well-being, and not just merely the absence of disease or infirmity. And COVID-19 is now shedding the light on all the other aspects as well, not just the disease itself, COVID-19 as a disease, but also what happens mentally, socially, and as well as physical issues related to COVID-19. A little medical refresher. I'm sure most of you now know how this pandemic started and what is this novel 2019 coronavirus. So in November or December of 2019, there were reports of 40+ residents of Wuhan, China, who developed the same type of pneumonia. And they all were traced back to have had contact with the same seafood market. It's not clear how many people were initially infected. And this virus was identified as a coronavirus, which is a type of family of viruses that hit the respiratory system. This virus is almost 80% or more genetically similar to the SARS coronaviruses of the 2003-2002 outbreak or the swine flu. However, it's more highly infectious, and that's why we're now wearing masks, because now we know that it is transmitted through droplet infection as well. And there are many potential risks associated with the virus that are still unclear. So we're still learning about what this virus can cause to the human body. We're now learning more about the Kawasaki disease, for example, in kids, when initially we thought it does not hit kids as hard as it does hit adults. Now we're seeing all these syndromes and issues that are developing in a higher number of kids than we anticipated. So the general issues with COVID-19 as a pandemic, it's really a once-in-a-lifetime pandemic that we as human beings are not socially conditioned to the mitigation and containment measures of strict lockdown for a long period of time, wearing masks. So we're learning as we are going and as this pandemic progresses. It is also a pandemic of misinformation in this era of social media and the internet. A lot of people are politicizing the issue. A lot of people are sharing information that are not based in science, which is the pandemic video, if you guys have seen that. And there's, of course, the confluence of crises. We're seeing now that higher rates of mortality and infection is in certain communities of colors, immigrants, older adults. So now it's exposing many flaws in our healthcare systems all over the world. It's also increasing the inequality gap that we already had as an issue that is completely rising. So now who's making most of the wealth, whose wealth is growing right now? It's the already wealthy people, while the rest of us are, or a lot of us are, losing their jobs. So this all also will shake up the system in ways that we have not seen before. Vaccine trials need time. However, unfortunately, a lot of them are now still in early phases, but we're hoping by the end of this year we'll have something ready in hand. However, the issue of also politicizing vaccine launching and having a vaccine that is easy to administer, easy to travel, that doesn't need refrigeration, doesn't need a freezer, could be hopefully orally, taken instead of injections. All of these issues now that we're thinking about when a vaccine is ready. I also like always to remind whoever is listening to the issue of refugees on the difference between a migrant, asylum seeker versus refugees. So a migrant could be a person like me who has left their home country. My home country happened to be Jordan, and come here to pursue studies. And then I had a job here and I stayed with my family. I had a family here. While an asylum seeker is a person who has formally submitted a request for asylum because of a well-founded fear or issue that's threatening their health and their well-being. Then they go through the process of asylum seeking, and those who are granted asylum are called refugees. So the language really matters, and I feel a lot of people usually mix up these terms, and that's where the confusion happens. So refugees are a specific population with very specific needs. So this is a snapshot of the UNHCR website showing the number of people who are forcibly displaced worldwide. And this is the highest number we've seen since World War II. And the number is expected to increase with all what's happening, again, with the increased inequality and climate change, a lot of things that are happening, increased violence. We are expecting this number to keep on growing. So the internally displaced here are about 41.3 million people who are internally displaced within their own countries, within the boundaries of their own countries. About 26 million people are refugees right now, who are living in countries that are not theirs, who have been resettled, and 3.5 people are asylum seekers. It's also important to know that most of these people live in the global south in low and middle income countries, like the country where I grew up, in Jordan. About 4 million people are stateless people right now all over the world. And 57% of all refugees come from 3 main countries: Syria, Afghanistan, and South Sudan. Syria is the world's largest refugee producer right now, as you know, since the beginning of the war in Syria in 2011. And I'll be talking a little bit more about this. Who are the top refugee hosting countries? So Turkey is one, Pakistan, Uganda, Sudan, and Germany. So again, the plight of refugees, this is the highest number we've seen since World War II. The rates are 45,000 people are being forcibly displaced or forced to flee their homes per day. So that's 20 people per minute and 1 person per 2 seconds are forced to leave their homes. So this is really a massive rate. The return to normality usually is difficult after conflict, if it happens. So if a person ends up returning back to their home country, it usually takes them 15 to 20 years to return if they return. In the case of Jordan, for example, where I grew up, most of the country is made up of Palestinian refugees who are not able to return back to their home countries. So really they lived for generations in Jordan now. They became Jordanians, so they have not returned back home. The same is happening to a lot of Afghani refugees, Iraqi refugees, etc. Again, this is just a visual illustration of the world's producers of refugees. Syria is the largest, followed by Afghanistan, followed by South Sudan. Somalia is one as well, Myanmar, Eritrea, Democratic Republic of Congo, and Central African Republic. So Jordan is the second largest refugee hosting country per capita. So really, if you look at the number of population, people who live in Jordan, we are the second worldwide. And Jordan is a country of limited resources. We're located in the Middle East, in the middle of a desert, as you can see. So we have a lot of issues to deal with. One of them is drought, for example. So we're the second poorest in water worldwide. And we're home to a lot of refugees, 52 nationalities. The majority of them, of course, now are Syrian, since we are on the border with Syria. So on the north here is Syria. We have a lot of Iraqis. So this is Iraq, and this is Saudi Arabia, and here is Palestine and Israel. Lebanon and Turkey share the load of having a lot of Syrian refugees as well. So Turkey is hosting the largest number of Syrian refugees, followed by Lebanon, and followed by Jordan. Most of the refugees live up in the north, as you can imagine, because of proximity here. So they make the trip from northern Syria all the way to Erbil here, Mafraq, and Amman is the capital. So the 3 largest cities in Jordan are home to the highest number of refugees. Only 1% of refugees usually make it to their tertiary destinations. So most remain marooned on a secondary neighboring countries, such as Jordan. So a lot of the Syrian refugees in Jordan were hoping to make their tertiary destination or their endpoint to Europe or the States or Canada, where they can have better opportunities and they can seek asylum and become refugees there. However, with all what's happening and all the anti-refugee policies going on in the world and rhetoric, as you know, and Europe closing borders, most of them stay in countries like my own, where I come from in Jordan. And as we said, most of the world's refugee burden is borne by countries like my own. The majority of refugees in Jordan, actually 80% of them, live below the poverty line. And here in the US, I've seen statistics by the Migration Policy Institute that say that more than 50 of refugees who live here in the United States live twice below the poverty level in the US. So this is one of the major issues that we face usually working with refugees, the socioeconomic status. And again, it ties it back to all the other determinants of public health, which are not physical in nature, but rather social and mental. So these are pictures from what we've seen before the pandemic, right? This is here on the border with Mexico, as you can see. This is Australia, refugee camps still exist. Colombia has been home to a lot of refugees from Venezuela, as well as, of course, the Malaysia's Rohingya refugees. So this all was a major problem, as you know, before the pandemic hit. So how is migration a social determinant of health? In public health science, we think of health as using this famous socio-ecological model of health, which is health is not just, personal factors such as age, sex, what you inherit from your parents. There are individual lifestyle factors, where you live, for example, your housing, all of that, social and community influences, living and working conditions, and largely, the socioeconomic, cultural, environmental conditions we live in. And migration really cuts through all of those, right? So if we think about how a refugee usually struggles and their health is affected as they are being displaced, we think of language and cultural barriers, the immigration status, health-seeking behaviors, what they've known about health before coming into the country, what services they can access, gender norms, safety, sensitivity to policies happening in the country where they're resettled, and largely also the policy and strategy across sectors. So again, for example, what kind of jobs they end up doing. What we're seeing now in the pandemic, for example, is that a lot of refugees are usually essential workers, right? They're Uber drivers, they're working in grocery stores, they're first responders. So they're being hit hard by the pandemic because of their living conditions, because of they work, because of where they work. And as an epidemiologist also, I like to study the issue of being a refugee and how it affects health by looking at the whole migratory route. So really the place of origin, what happened before, what happened in Syria, for example, and then the travel and transit, what happens in Jordan before you ended up being resettled in the United States. So I like to study those as well. And then the place of destination, your final place of destination. What's your legal status right now? Can you access healthcare or not? What kind of healthcare you can access? What languages are you speaking? How long have you been staying here? So, recent arrivals, they have a whole lot of issues that are completely different than those who are second generation refugees or who have been here for a while, right? And return if they end up returning or going back home. So really looking at a snapshot in time is not the way to understand causality, which is the basis of epidemiology, understanding what causes what. You have to look at the entire migratory routes and understand where these people came from, what happened during the migration, the migratory route, or the migration process, and what is happening where they're at right now. So now refugees are being regarded as the world's most vulnerable during the pandemic, and all eyes are on what's going to happen if an outbreak happens in a refugee camp. As you all know, probably the camps are usually overcrowded settings. Where I work in Jordan, Zaatari camp, it's in the middle of desert, so really extreme weather conditions that do affect coronavirus, as we know. So now we believe that the virus is more stable in hot weather. So we don't know what will happen now that in places like Jordan where there's extreme weathers, how is this virus going to behave? I will be talking a little bit more about the numbers in Jordan, how many have been infected versus none. The camps are lacking adequate resources. So as you can imagine, there is no running water, for example, in a lot of other camps in Jordan, such as Azraq, right? Because again, it's in the middle of desert because of drought being a big issue in Jordan. One strategy that is now being practiced in camps, especially in Zaatari, which is the one I'm most familiar with, and Zaatari is the world's largest camp for Syrian worldwide, and it's the second largest in the Middle East. So it's home to about 90,000 Syrian refugees. One strategy now that is being practiced in Zaatari is shielding. And it's a public health mitigation and containment practice that means you put the most vulnerable, older people, those who have predisposed conditions such as hypertension, cardiovascular disease, cancer, you put them together to shield them if you cannot do really these physical distancing, right? Because those trailers that refugees live in are very close to each other. So they ended up moving people who are at risk to another side of camp. And this is called shielding. Access to healthcare is limited. And in general, I'll be talking a little bit about where refugees live. Are they all living in camps, or are they living outside in urban settings? Actually, a third of refugees worldwide live in camps. So they have very different needs, those who live in camps versus those who live outside camps. In camps, for example, healthcare is offered by the UNHCR, usually through clinics that are all over. I happen to work in one in Zaatari. However, this is all primary care that they receive over there. We don't have hospitals to do operations, so we need to transfer whoever needs surgery, for example, outside the camp. And as you can imagine, at a time of pandemic, and at a time when there are lockdowns everywhere, all of these are, processes are hindered. Usually refugees, as we said, are the world's poorest. The majority of refugees live below the poverty line and are struggling on a socioeconomic status basis. There are usually tensions and stress between hosting communities and refugees. This happens everywhere, as you can imagine. In Jordan, luckily, because the country has been used to accepting a lot of refugees since it has been founded, I feel that these tensions are less evident than what I see here, for example, or in other parts of the more developed world. Let's say, although I hate to use the term developing and developed, there is vaccine hesitancy among refugees, and we know of this. We know of this in Jordan as well with TB, with other things. As you can imagine, these people are very vulnerable. They have a whole lot of issues they're dealing with when they are being displaced, and there are a whole different healthcare system that they have to navigate, and a country that is, putting on new policies for them. So we see that refugees usually are reluctant to receive vaccines. So this is something to think of as a vaccine becomes readily available for the coronavirus, the novel coronavirus. And more border closing, as you can see now, are happening. Just here, the US-Mexican border has been closed, for example, and we'll talk a little bit how that's affecting asylum seekers. Walls are being built, confinement to camps and shelters. All of this, again, is just putting people in camps, shelters, closing borders. This is very relevant to the plight of refugees and what people are already feeling when they're being displaced. So this is a paper that we've done about 3 years ago that was the first of its kind to really characterize the health needs in camps versus outside camps. So when people think of the health of refugees, they have to think of where they live and what kind of needs they, are there, and priorities that we could design public health interventions for, policies for. So in this paper, we sampled a large sample of refugees inside camps and outside camps in urban settings in Jordan, and asked them. We did a lot of interviews. Then we did a quantitative piece to it, trying to, again, characterize and make the differences clear so that we can prepare for designing interventions and policies that could work for different people in different settings. So these are some of the results, and you can find the paper probably online if you're interested. But the camps, as you can imagine, poor living conditions exacerbate respiratory illness. Again, living in a desert, as you can imagine, would affect respiratory illness. So these are all perceptions from what people have told us. So people are aware, refugees are aware that, and they've been complaining that their respiratory tract is being affected. Those who are asthmatic, for example, living in a desert are complaining about it. High costs of basic foods and unregulated stores and camps. This was a big issue. For example, usually the UNHCR and the World Food Bank offer credit cards for all of them. prepaid cards that they could use in stores. Some of those cards got stolen. Some of them usually are unavailable. So a lot of issues regarding availability of food. Lack of transportation to health clinics inside camps. So the camp, as I said, is Zaatari camp is home to 90,000 refugees. So it's a whole city. You can't see the borders of it, right? So it's really big, and most of them usually walk, right, to get to health clinics. So a lot of complaints were around that, and there are a lot of stories of innovation that I've talked about in a little bit. On, for example, thinking about bicycles, and now a lot of NGOs are providing bicycles inside the camps. Inadequate security. So the Zaatari camp, and at the background, all of these pictures are pictures I've taken throughout the years. This is when, this is in 2012 when the camp was first established. So as you can see, it was tents that the refugees lived in. And then later, a major flood happened. Like, it rained so hard that a lot of people died in the camp. And that's when the UNHCR decided to install trailers. So this is at the beginning of it, this picture, at the beginning of the foundation of the camp. There are a lot of issues regarding gender-based violence. So at 4 p.m., all NGOs, all NGO workers leave the camp. And after 4, it transforms into this very different place. And again, you cannot blame the refugees, right? You put people in places like this that are unlivable conditions, and then a lot of these issues rise to the surface. Child marriage is a big issue, and I remember a lot of my patients would come with their children, and I would talk to them about child marriage, and it's not a good idea. Why do you want to marry your daughter off? But then the conversation ends up, I cannot provide her with food, right? So maybe somebody else could. So it's a very tough situation, very difficult conversations that we usually have with refugees over there. Now in urban settings, a whole different story, because these people live outside camps. They don't have this kind of confinement. There is limited access to secondary and tertiary healthcare. So in Jordan, for example, the country has provided free healthcare to all refugees up until the end of 2014. So about 4.5 years into the conflict, into the start of the influx of refugees, the country was offered free healthcare completely. Because we have a universal healthcare coverage in Jordan. Then the country could not afford it, so people had to pay a little bit of money. And again, it's a circle, right? Because refugees are not allowed to work as well. So how could they provide for, to pay for these healthcare services? So it's really, really a difficult situation. Chronic conditions are perceived to be more prevalent since displacement. So a lot of the refugees who had hypertension, who had diabetes before, who had kidney disease, they believe that their conditions worsened over time since displacement. Access to medications is one issue, for example, compliance to medications, being able to see the doctors again. Mental illness is a big problem in refugees in general, as we know. Usually the prevalence of mental health issues in refugees is more than 50%. In Jordan, I know that more than 50 have had suicidal thoughts in refugees. So people have thought of ending their lives at one point in time. Lack of legal work opportunities. So after we've published actually this study, the Jordanian government has picked it up, the media has picked up this article, and they started conversations on, okay, so how can we make sure that we have enough legal work opportunities for refugees when our own problems, as a country dealing with unemployment and, all the economic crises that are happening in the region. So they're loosening a lot of those policies. They have been a lot of under the table, being able to work. The government lets it happen because, again, how could these people survive if they're not allowed to work? the poor housing conditions. So even in urban settings, most of the refugees live in unfinished buildings, in certain areas where socioeconomic status is low, where water quality is bad. So yeah, we kind of characterized all of these issues and these differences. So healthcare access, although more available to refugees inside the camps, is not the kind of healthcare access that you would like to provide to people, right? It's just very much basic needs, primary care. While outside the camps, they have access usually, but again, they are not allowed to work, they can't pay for it, as well as we cannot usually locate refugees outside the camps. So inside the camps, things seem to be more organized in terms of the NGOs, the different NGOs working. So UNICEF, for example, is focusing on children's health, and they know exactly what's happening inside the camps. They're well organized there. While outside, refugees are scattered all over the place, so it's hard to identify them. It's hard to reach out to them. So the refugee experience, this is what we refer to in public health as the refugee experience, which is really mental health more than anything. And it varies not only among refugee groups, but also among individuals. And that's what makes it difficult to kind of really characterize and study, because different experiences, where you come from, where you ended up, that migratory route, what happened along the migratory route, those are all, they differ among individuals. They're usually complex, and they contain numerous trauma and stressors. And a lot of my work now is focusing at understanding these stressors, right? What type of trauma? Is it a complex type of trauma? How could we assess it? All of that. Approximately 5 to 10% of refugees in the United States have experienced a form of torture, including electric shocks, beatings, rape, forced witnessing of torture, of executions. Many refugees experience usually loss of contact with family members. And now we know what's happening in the United States. The refugee ban that happened, for example, has really affected the reunification with family members. Since many of them are in Somalia and other places, they're really experiencing active violence and war. All refugees have experienced a loss of home, loss of livelihood, and relocation stress. And of course, the research supports the relationship between trauma and mental health. So we know that, what's happening to their mental health is caused by all this kind of trauma. The amount of trauma matters, the type of trauma matters, and the duration of trauma matter. So you probably all have access to the Johns Hopkins map. This is what most of us are following these days to see the total number of cases of coronavirus. So now the world, as of yesterday, the number of cases was almost 7 million worldwide. And the number of global deaths is approaching 400,000. As you can see from the map, the epicenter of the pandemic is now North and South America, as well as Europe. We still don't know how the virus is behaving in Africa and other parts, including the Middle East. We are now worried about what's going to happen when the virus spreads across Africa. We don't know how this virus is going to behave with underlying conditions that are prevalent in Africa, for example, such as tuberculosis, HIV/AIDS. What will happen is yet to for us to kind of study and see. So these are the countries that are most affected by coronavirus today. Those are 10 countries, as you can see. The US is believed to have started flattening the curve, although, with all the protests now, it's what's happening, all the fears now of us as epidemiologists and public health practitioners are with all these mass gatherings. How will the virus behave, and will we have second waves or not? Brazil is now also, having a large number of cases. And India is a place also we're keeping a close eye on because the number of cases are rising there tremendously. So what is happening now for refugees and COVID-19? We are seeing some outbreaks starting in Greece. There was one in a migrant shelter very recently where there was an outbreak. All what's happening is not being directly reported as well. So and it's very much politicized. That's why it's hard to understand what's happening completely. However, I know in Greece, for example, there was lockdowns on refugee camps and islands where migrants live, and not the rest of the country for a long time, which increased these kind of, this kind of stress and tension between refugees and the government. There were outbreaks in Turkey and in Germany. Africa and the Middle East and other parts of Asia are expected to have more waves. We are always praying and waiting for news on what's happening in the Middle East, for example. And I will be talking about Jordan more now. There is increased xenophobia and racism, asylum process delays, as you can imagine, more borders, more walls. People are panicking. People think that, refugees or migrants are going to bring in disease. So there's a lot of that. And there is an increased deadly sea route from Libya. So a lot of people who are taking the sea route from Libya there are a lot more people taking those dangerous sea routes during the pandemic. This is also a picture I like to always put in my slides, and this is Syria, which has been named one of the biggest humanitarian refugee crises of our time. So for Syrian refugees, 10 years of ongoing conflict since 2011. About 6.5 million people fled the country since the war began in Syria. 6.5 people are inside the country. So a lot of them are internally displaced. The country is war-torn completely. It's not functioning. So Idlib, which is the main city that's being, it's the battlefield. There is increased death toll due to atypical pneumonia, lack of testing. There are no ventilators, no personal protective equipment. It's a war-torn zone. And what you hear in the news probably is a fraction of what's happening, right? Because again, it's an active war zone. Jordan is hosting third of the largest number of Syrian refugees worldwide, as I explained in the map. So first Turkey, and then Lebanon, and then Jordan. In Jordan, the total cases since the beginning of the pandemic is, as of yesterday, is 795 people that were infected, and the total deaths are only 9. Now, Jordan took very early measures of extreme mitigation and containment. So they did lockdown, everything. Nobody's allowed to go to work. Everybody stay at home. And I am actually proud of this because they have been able to control the pandemic really well so far. Lebanon is hosting the second largest number of Syrian refugees worldwide, and they're starting to report some outbreaks in camps. I've just seen some news coming out of Lebanon on one of the camps where they've had diagnosed 10 people with COVID-19 so far. So as you can imagine, in camps, it will be the worst nightmare for any public health practitioner. Overcrowded settings, no way to test everyone, no possibility to do physical distancing, and people are panicking, and some of them don't want to come forward if they have some problems. A lot of health literacy issues, so a lot of risk communication problems, and I will be talking a little bit more about this also. In Lebanon, I'll have to say that the situation of refugees, Syrian refugees in particular, has been more difficult than it is in Jordan because of historically Lebanon and Syria were at some point in time not on good terms. So, the whole tensions between the Lebanese and Syrians, and plus the economic crisis that Lebanon is suffering from right now. So all of this is making providing better healthcare for the Syrian refugees more difficult and more challenging in Lebanon. Yemen is a country also that I wanted to shed the light on since I've worked in Yemen before. It's a very interesting country. One of the world's oldest cities was Sana'a for human civilization ever. There is ongoing conflict, as you know now. It's one of the world's also worst humanitarian crises. Famine is a big issue. People are struggling with providing food. According to the WHO, there are no cases so far. The virus outbreak over there would be deadly since we know that the country is struggling on so many fronts. There have been frequent cholera and TB outbreaks in Yemen, so we are kind of on the watch for what's going to happen if a case was identified. The healthcare system is devastated, as we said. International borders are closed, except for cargo, which is a route that Yemen heavily now rely on for basic needs, fuel, food, and other essentials. Afghanistan, which is again the second largest producer of refugees worldwide now, 40 years of conflict, millions fled to so many countries. 3 million Afghani refugees are in Iran now. 2.5 Afghanis are internally displaced. Iran is a hotbed for COVID, as we know. This is a picture of the mass graves in Iran that have been taken by satellite. It is reporting the 4th highest number of deaths worldwide now. The health system in Afghanistan is devastated. There were 320 confirmed deaths due to COVID-19. There is a lack of testing or control measures. 39 million are estimated to be infected in Afghanistan. And there are 3 doctors in Afghanistan per 10,000 patients. So as you can imagine, there's a huge issue with access to healthcare and accessing testing and all of that. Finally, I'll take you to the United States where we are now. Before the pandemic, as we know, the US returned 60,000 asylum seekers to Mexico under the MPP, the Migration Protection Protocols. So the country has been struggling lately a lot with all the policies regarding asylum seeking and being a refugee in the country. There were border closures. Mexico's situation is bad now. It's believed to be also one of the epicenters in Latin America. Within Latin America, it's Mexico and Brazil now that are reporting the highest number of cases. Mexico agreed to accept most Central American returnees from the United States, except unaccompanied minors. It's unclear situation for Cubans and Venezuelans, if deportation will happen from Mexico or not. And the NGOs working with refugees are forced to reduce or cease operations. So some of my friends in the infectious disease department here at UCSD, for example, stopped going to the migrant shelter because they're down to 0 cases. They don't have anybody there. So basically this program is now being stopped because of the MPP or the Migration Protection Protocols. We believe that Mexico is not doing enough testing and reporting of cases. There's also a lot of atypical pneumonia diagnoses happening off of Tijuana that we're kind of concerned about. So, there's a new School of Public Health happening at UCSD, which is really exciting. It's really difficult time, and the school is being challenged in many ways to, with all what's happening in the world. But this is a commentary, an op-ed that Dr. Cheryl Anderson, who's a founding dean, and myself wrote about some of the issues that refugees here in San Diego are struggling with. San Diego is the 2nd largest refugee resettlement city in the United States. And it's home to more than 50% of California's refugees. Refugees here come from different parts of the world. This picture kind of illustrates it. But we've received the largest batches of Syrian refugees within the past 3 years, more than any other place in the United States. There is a high concentration of Somali refugees, Iraqis. And in this article, we talked a lot about how this population is suffering in a way that we are not able to characterize and talk about because we do not have disaggregated data by refugee status, right? So we have data for Black Americans, Latinos, Pacific Islanders, all the other minorities, the major minority groups that we usually assess health by. But for refugees, we don't know what's happening. However, in this commentary, we kind of talk about anecdotal evidence from different doctors here that are talking about how they're admitting a lot more refugees and people from certain countries that were here as refugees to the ICU. And this problem is not being, talked about a lot. So undocumented immigrants is one, for example. California is leading the way and starting to think of ways we could help this population. So they started offering $500 in COVID aid, which a lot of people are arguing this is, not enough for anything, but still it's a gesture of, we care. So what are the solutions and the opportunities that we can think of now as we move forward with the pandemic, and as it still kind of becomes clearer to us what this disease can cause and what this pandemic can cause? COVID-19 should not be used as an excuse to enforce deadly migration control policies. So all of us as activists and scientists, researchers, wherever you come from, we should advocate for that. These deadly migration policy controls will benefit nobody, really. COVID-19 is proving to be a disease and a virus that does not respect borders. We are all in this together. So these control policies will only disproportionately increase the misery of refugees. Ensure human rights are respected as we start these mitigation and control measures that are unfamiliar. We're unfamiliar for strict lockdowns. What happens to refugees when we ask them to stay at home? How do refugees usually, what kind of jobs do they work? Are they able to follow these measures or not? Refugees, for example, culturally, they live with extended families more than others. How does this affect an older person who lives with a family where somebody is an essential worker and cannot comply with these mitigation efforts? We need to start thinking of more personalized, group-specific measures. Lockdowns and mass quarantining cannot be cut and pasted. Again, special groups like refugees, we have to think of how we communicate these mitigation efforts. How do we talk about vaccines? How do we talk in a way that is non-discriminatory? How do we engage them also in as community members, community leaders in designing those policies as we move forward? Evacuation whenever possible. So in places like Jordan, where people live in refugee camps, we have to think of evacuation plans in case the disease spreads. What will happen? Which hospital will receive what? Safeguard access to healthcare for all. Invest in public health preparedness research. And this is something that the School of Public Health here is committing to. More public health preparedness research, more equity research for specific groups like refugees. And pave the road for equal rights for refugees. So this actually could be an opportunity for us to come together as countries, as different experts, as us as scientists who have been advocating for equal rights for refugees for a long time, to come together and start talking about really how we move forward now. For example, Portugal and some other places like Italy, they started to give equal citizenship rights to refugees because of the pandemic. That's a great sign. We want to hear from them on how this has affected their country. Has it really worsened things or has it improved things? So maybe we should then learn from these countries, right? And this is a really nice illustration that I like hugely to include. Inequality, as you can see here on the top left, is the unequal access to opportunities. Equality is to evenly distribute these opportunities and tools and assistance, which doesn't necessarily serve all the different groups. And then equity is to custom tool these, these tools you are using so that they can identify and address inequalities for special people. We do different measures. And justice is really fixing the system to offer equal rights. So justice is taking it one step further and thinking of how can we reform the healthcare system, for example, in the United States, so that equal access is granted for these groups that are suffering the most during COVID. This is a little bit about my own research endeavors now at UCSD. One project of mine is a 5-year project funded by the National Institute of Health looking at hypertension in refugees. We know that stress is linked to hypertension. Hypertension, uncontrolled hypertension in particular, is a big problem for refugees. So we will be experimenting for the next 5 years on ways we can deal with this issue of uncontrolled hypertension by engaging refugees themselves and measuring their own blood pressure at home and self-titrating their own medications. So we are shifting from dealing with healthcare only at the hospital or clinical settings to taking healthcare to their homes. So, dealing with a lot of language and cultural barriers, accessing healthcare by empowering patients themselves. Another project is looking at the effect of trauma on cognitive health of Syrian refugees in Jordan. And this is a project funded by the Alzheimer's Association. So a lot of my Syrian refugee patients in the clinic were complaining of being forgetful at a younger age. And we don't know whether the type of trauma that they've been subjected to really affects their memory function. So we will be looking at that. We learned a lot from veterans, US veterans, that they are more forgetful and that the trauma they've witnessed on the battlefield in other countries has affected their memory. So we will be studying that. For here in San Diego, we will be looking at perceptions around dementia risk and diagnosis in older Arab refugees. So I will be focusing a lot on the Somali and Iraqi refugees and Syrians as well, understanding how much they know about dementia and preparation in the future, hopefully, to carry out more work with them on this. And then finally, very recently, we've been funded to study the social, behavioral, and mental health effects of COVID-19 in refugees. And that's actually a supplement for our work on hypertension. So we will be surveying refugees on what's happening in their household. Are you able to follow the strict lockdown or not? What kind of job do you have? Have you lost your job or not? We will be able to quantify that and characterize it. As well as we want to study how the shift to telemedicine has affected their health. Are they less likely or more likely to access healthcare because of telehealth? Has it made it more easier for them to sit at home? Do they have access to the internet or not? All of these things we're starting to study and characterize because of COVID-19. So again, COVID-19 is providing us with resources and funding to do this, which hasn't been happening before. So it's really exciting in that sense. There are also stories of hope happening all across, stories of innovation. These are two good friends of mine at MIT. When I was in Boston, I knew them. Those are Syrians themselves. Their parents were immigrants from Syria. And now they are creating a screening tool for refugee population with Microsoft, an app that could be used readily available on the phone that they could download so that they could use it as a screening tool that is specific for refugees and ask a lot of questions on mental health, for example, and trauma and whatnot. And refugees themselves are really stepping up on the front line to fight COVID. So a lot of them are making face masks. A lot of the Syrian refugees in Jordan are making soaps. So they are being very creative and innovative, and they really want to show the world that they are not just, to be considered a burden on societies, but rather an asset and people who are in this fight with everybody else. And finally here, for example, in the United States, a lot of the Syrian refugee doctors who are very well trained in Syria, because Syria really had a strong medical school system, they want to be able to contribute. So there are a lot of conversations around that, why don't we let them contribute? How can we let them contribute? How can they practice medicine despite the fact that they haven't taken any of those exams, those very expensive exams that they have to take to be able to practice medicine here in the United States? So again, a lot of conversations now are happening because of this pandemic, I feel, which is really a positive sign in that sense. Finally, these are some of pictures of us working in Jordan, different settings and different activists and people from different groups who are interested in the refugee crisis issue. Thank you. I like to always end with this Arabic proverb, a little bit of my culture to you all. If you have much, give of your wealth. If you have little, give of your heart. So I hope that all of you can contribute to the plight of refugees in one way or another, even just if it could be by empathizing and feeling for them. Finally, this is my email address and my Twitter. Feel free to reach out with any questions after this if you couldn't ask some questions here.
Thanks very much, Dr. Al-Rousan, for sharing your expertise. If you have questions, please send them to me by chat, and I will communicate those to her directly. We already have a couple of questions. One of them really plays off what you just said about a call for action, and some folks have questions about specific kinds of action that they can take. One coming from our visiting scholar, Kathy Kopanak. Is there a specific fund, a specific fundraising mechanism or organization which you would recommend for people who are interested in donating for the alleviation of COVID-19 for refugees specifically?
Sure, great question. Thank you so much. I think PANA, let me see, PANA is one that I could send it to you. This is the Partnership for the Advancement of New Americans. It's the biggest organization here in San Diego that really serves refugee families. PANA, sd.org is a place you can really donate, and they have a goal of 150,000. They already raised 141,000, which is exciting. So go ahead and feel free to donate to PANA. They're great.
That's panasd.org, you said?
Yeah. Yes.
I'll send that around to folks if they're interested.
COVID fund, yes. Mm-hmm.
We also have a question from Sadia Lira. Hi, where can I read more about the screening tool created for refugees?
Sure. So I could send you. It's called the Self-Check Screening Tool by MIT.
Self-Check Screening Tool by MIT. Okay. Then a question from Tom Shortash, my colleague in anthropology. Please say a bit more about your mental health work, and particularly the interface between the epidemiological research and provision of clinical care.
Mm-hmm. Great question. So I have some work on mental health in Jordan, as well as here at UCSD and with refugees here in San Diego. Some of my work in Jordan is very tightly tied to cognition. So really, I'm looking at the type of trauma and the amount of trauma using the new ICD-11 complex PTSD as a diagnosis, how that is related to cognitive functioning. And I assess cognitive functioning using the tablet, a new UCSF screening tool that can work across cultures. So this is also novel in terms of, you don't have to deal with translation, because a lot of the memory testing had to ask people things that are, different in different languages. So we are being here innovative in testing memory as well. For the mental health aspect, we're looking at PTSD, depression, and anxiety, as well as complex PTSD, which is a new ICD-11 code as well. For here in San Diego, I'm looking at a COVID questionnaire that has been developed by the NIH that looks at psychological stress more than mental health diagnoses. So we're following the CARE pandemic questionnaire, CAIR, and we're going to be surveying 100 refugees, 100 non-refugees, so matching refugees using propensity score matching, and we will be asking a lot of questions on psychological stressors related to COVID and how that affects hypertension management and different cardiovascular output.
So that leads me to a question, which is that you started out saying that refugees are the most vulnerable population to COVID-19, I believe. And there's been a lot of discussion about this in the news and social media. What do you say to those who say, sure, refugees are highly vulnerable, but they are no more highly vulnerable than other poor populations, often living in very dense urban areas in particular?
Mm-hmm.
What is specific about the refugee condition in those kinds of settings that makes them more vulnerable?
Great question, David. I think, now we're faced by these very difficult questions on my problem or yours is worse, right? Different minority groups feel that COVID is stressing them the most. So it's really difficult to say whose disaster is worse than the other. The pandemic is affecting us all to start with. There is a mental health crisis happening to all of us. There is people losing their jobs, etc. But I feel that for refugees in particular, there are two issues of vulnerability. One is where they live. They live in settings that are really difficult. And I talked a lot about camps. Living in camps, it's really difficult situation, overcrowded settings, limited healthcare services, a lot of issues related to security to start with, gender-based violence, child marriage, a lot of issues that are affecting public health that are completely kind of intensified in these settings. While for those who live in urban settings, they're also living on the margins of societies. Many of them are not able to access healthcare, and many of them, when accessing healthcare, have a lot of language barriers, cultural barriers, plus the fact that refugees have been living on the margins before the pandemic started for a long time, with policies that are clearly discriminating against them, such as the refugee ban. So I think it's hard to say whose problem is worse than the other, but at least we can say that these are people that have been suffering for a long time. And, countries have been kind of raising their hands and saying, it's not my problem, it's yours. It's Mexico's problem. No, it's the US's. So it's about time we kind of really think of them as human beings, humanize the issue, and understand that all of us are in this fight together.
So if there are other questions, please send them on the chat. I have a question relating to, I know you've done a lot of work on migration and refugees generally beyond this particular pandemic. Is there anything about being a refugee at a population level that can reduce the risks of harm? Something having to do perhaps with positive selectivity for health for refugees, or the fact that in camps, yes, people are overcrowded, conditions are bad in many different ways, but at the same time, there are also agencies that have a great deal of surveillance and control, potentially that could be used for contact tracing. In other words, is there any upside to being a refugee, as silly as that might sound at first, or is it all relentlessly negative in every way?
That's a wonderful question, and thank you for that, because really the narrative needs to be carefully navigated in terms of, oh, these are people that are suffering and are a burden, but also these are people that we could learn something from. And I think the biggest thing we can learn from refugees in general is resilience. Resilience is a protective health topic that or health exposure that we could all use during this time of pandemic. I think really refugees are more resilient than any other population I've worked with before. I've worked with prisoners before, older adults, gender-based violence victims, etc. But the stories of strength and the human ability to proceed and be able to see the best of places like a refugee camp is really striking in refugees. So in other words, I think people who are used to disasters and who are used to living in conditions that are really difficult are also strong and are people we should look up to for this kind of resilience and these kind of stories of being able to survive despite the fact that we can't leave our homes, that are we confined to our homes. Think of refugees who are confined to living in a desert for years and years. There are generations that are born, live their entire life in refugee camps, and die in refugee camps. So I think there's a lot to learn, and it's a really great question.
Thank you. See, I'll give people if they have we have a couple of minutes left. If anyone has a question while we're waiting here, we'll wrap up in a few minutes. But you talked a bit about your own research agenda that you're developing for the current and forthcoming projects. You know, we run a multidisciplinary migration center here. Refugees and asylum seekers, asylees are some of the populations we're interested in. Is there research that you would like to see other people doing, perhaps in a different discipline, that would help answer questions that you have that you're not able to do because you're focused on those projects that you outlined for us?
Sure. You know, David, I'm a big fan of your work and of the CCISD in general, and I was always trying to think of ways we could collaborate since I moved here 2.5 years ago. I think there's a lot we could do in terms of thinking together of changing the narrative around being a refugee. Things you just highlighted, for example, right now, what can we learn from societies that survived wars and that survived these extreme conditions now more than ever before? What could all of us kind of connect with? These are things that, for example, I cannot, as an epidemiologist or as a healthcare researcher, really put my hand on, that I would love other social scientists, different people from different disciplines to kind of navigate as we develop these research projects. I think there's a lot of exciting energy. I was so surprised that the National Institute of Health is finally believing in refugee health work, that they've funded this 5-year project, and it's really an exciting time for us also with the new School of Public Health starting. So I think there's a lot for collaboration for people from different disciplines to contribute in different ways and complement. I think the 4 projects that I've outlined, I kind of deliberately outlined these specific projects, although there are some other that are being developed, because I think those are areas that we could definitely, collaborate on in terms of hypertension, self-management. For example, I'm studying very much the intervention, what will it do? But I'm not studying, for example, how does spouses, kind of behave when I introduce such an intervention. Does a wife help her husband comply with that or not? Does the community leader, interfere? So all of these are issues that I would love to explore in the future.
Clearly there is much work to be done. We'll take a final question again from Sadia Lira, who says, HCPs, I'm not sure healthcare providers, healthcare providers that work with refugees, such as doctors and nurses, do you feel they are equipped with skills such as empathy to understand the psychological dilemma or trauma that refugees may have faced to provide them with adequate care? So what I'm trying to say, do you feel they communicate appropriately considering the background of their patients, or is there room for improvement in this area?
That's a great question too. Thank you, Saida, for that. I think it differs really in different settings in different countries. I think in a country like Jordan, where we grew up with the idea of you are a nation of refugees, it's embedded in our curriculum as medical students, for example. So we had a lot of courses that, when I compare to some of my colleagues who have gone to medical schools here, that are different, that are geared towards that, toward trauma, toward resilience, toward stress, toward what it's like to be displaced. It's not really, but we had a lot of classes, for example, talking about that. While here, I'd like to start pushing for that more, because a lot of research is showing exactly that. It's showing the cultural incompetency, the fact that most of healthcare providers, for example, now with COVID, it's even worse, because there are some papers coming out now, some editorial pieces from different providers saying, refugees, when they see us wearing masks, it's even increasing these barriers and creating more of, oh my gosh, I'm scared, I can't understand what he's saying, and now he's wearing a mask, and so all of these things, I think, even now are more important than ever before, conversations we should be having and talking about.
Well, we're grateful for your intervention. Congratulations on the grant that you just mentioned. That's very exciting. And we look forward to inviting you back to share the results of these programs that you've outlined.
Thank you so much for having me.
Thanks to everyone else for joining. Thanks for your questions. And we will reconvene in the fall. Everyone and their families, I hope, is able to stay safe and have a productive summer. Thank you.